Emcure Pharmaceutical welcome all of you. We at Emcure are proud to present the National e-webinar series on Acute MI. Today is the seventh session of this e-webinar series, which is an initiative taken up by Emcure Pharmaceuticals. In previous workshops, we had very unique and interesting discussions ranging from the management of STEMI to thrombolysis and the complications in STEMI. And we are looking forward to having a fruitful discussion today as well. The objective of this workshop is to educate and update the healthcare practitioners on the effective management strategies in patients with acute MI in the current real life scenario and gain insights and wisdom from the expert. It is my esteemed honor to introduce our chairperson for today, Dr. Pramod Kumar sir, who is a senior consultant cardiologist from Apollo Hospital, Chennai. He has completed his MBBS and MD from Calicut Medical College and DM from Kottayam Medical College. He has over 25 years of experience in cardiology, and he's also published articles in reputed national and international journals. His special interests include coronary intervention, valvular intervention, etc. I welcome you, sir. Next, I would like to introduce our moderator for today, Dr. Vinod Kumar sir, who's the Associate Professor and Consultant Cardiologist, Department of Cardiology, Sri Ramachandra University, Chennai. His field of interest is interventional cardiology and epidemiological research in diabetes and cardiology. He's completed his fellowship in intracoronary imaging, observership in interventional cardiology and structural intervention. He's also the co-founder of the C3 Research Foundation. He's been a part of organizing committee in various national and international conferences. He's also published a number of papers and posters in various national and international meets and publications in reputed journals, including the BMJ. I welcome you, sir. And finally, it is my immense pleasure and honor to introduce our expert speaker for today, Dr. Amit Satur, sir, who's the Senior Consultant Cardiologist and the Director of Cath Lab, Sucharaya Hospital, Hubli. He has had over more than 9 years of experience in cardiology. He's the Secretary of the Northwest Karnataka CSI chapter. He's also completed his advanced interventional cardiology training at the Mayo Clinic, USA. He's published articles in reputed national and international journals, and he's also delivered lectures at various conferences. He's also part of the first heart failure clinic in North Karnataka. I welcome you, sir, for today's AMI session.
Thank you.
For the benefit of the audience, let me brief you all on the meeting agenda of today. We will kickstart the program with our opening remarks by our chairperson, Dr. Pramod Kumar sir, followed by context setting for the webinar topic by Dr. Vinod Kumar sir. This will be followed by the talk on the topic how to deal with large thrombus load in STEMI by our speaker, Dr. Amit Satur sir. Following this, we will have the Q&A session and discussion, which is open to all. I also request the audience to actively participate in the discussion. This will be followed by the concluding remarks by our moderator, Dr. Vinod Kumar sir. Now, I would like to hand over the session to our chairperson, Dr. Pramod Kumar sir, for his opening comments. Over to you, sir.
Yeah, thank you for your nice introduction. And, this large thrombus burden is always a nightmare for us in the cath lab. When we do, especially for the primary, when we do the primary angioplasties, many times we'll be in a, difficult situation, whether to go ahead with angioplasty or whether we have to wait and do some pharmacological approach. And all of us know that this large thrombus burden is always associated with a high mortality. And also, we have a quite high incidence of no reflow phenomena and also distal embolization and cases of stent thrombosis with the large thrombus burden. So I'm sure that today's topic will be of interest for everybody. And let me hand over this thing to Dr. Vinod Kumar, who has got quite a lot of experience in primary angioplasty. And Vinod will be moderating the session today. Over to Vinod, please.
Thank you, Pramod sir. It's always a pleasure to chair your section along with you, sir. And today's topic is one of the very good topics that to be addressed in any meeting, because being a cardiologist who run a 24 by 7 primary program, we all know it's how difficult it is for a mental status of a cardiologist to be working in a night primary at 2 a.m., getting a call of about age 35 years or 40 years. Young people nowadays are coming to with MI, major MI, with cardiogenic shock, with significant hypotension on multiple support systems. And when you take them to a lab and try to open the vessel, we found a lot of thrombus burden in the vessels. So our strategy of using dual antiplatelets, GP2B3 inhibitors, thrombosuction devices, catheters, various maneuvers, all help us to address this thrombus during a primary intervention. But even though we do a lot of intervention strategies, a lot of times we feel a difficulty to get over this. As Sir said, as Pramod Sir said, we find a lot of times we are ending up with a no reflow phenomenon. Or even once the stent and come out, the thrombus burden, after a couple of days, we end up with a stent thrombosis with a large thrombus burden. So it's always a difficult scenario to know what to do during a MI with a young patient coming out with a cardiogenic shock, with a lot of thrombus burden, might be a smoker, no other comorbids, and he lands up at mid of the night, and we have to make a decision whether to stent or not, how much should stent, whether only medication should be sufficient, whether to lyse the patient, all comes into our thinking pattern. So what happens is we always left with fewer drugs. So after probably the last couple of years, we see the usage of tenecteplase as a thrombolytic agent with an intracoronary format has increased, has gained importance when we are dealing with young patients. Whenever we are dealing with the young patients, along with GP2B3 inhibitors, whenever the thrombus burden is on a higher side, we have started lysing the clot intracoronary. So this is one of the additional support system currently we have to tackle very complex patients with a large thrombus burden. Today, it is it's a big pleasure to invite one of our colleagues to present such a case on a high thrombus burden, how he has handled, and we are all waiting to listen from him. It's going to be a nice thing. Post this presentation, probably we will all have a very good discussion on the same. Thank you. Thank you for the opportunity.
Yeah. At the outset, I would like to thank Emcure for giving me an opportunity to be in this very unique AMI workshop. I acknowledge the presence of Dr. Pramod Kumar sir, and thank you, Dr. Vinod Kumar sir, for setting up the stage. Yeah, so I would be talking today on the approach to large thrombus load in STEMI. So first, I would be presenting a case and then highlight upon the latest recent probably approaches on how to deal with a high thrombus load. So here was a 40-year-old female, no premorbid illness, non-diabetic, non-hypertensive, no family history of IHD, chest pain of 3 hours duration, EKG showed acute inferior MI, echo, there was regional wall motion abnormalities of the inferior wall, inferior part of septum with preserved ejection fraction of 50%. There was no MR. As primary PCI's current standard of care for STEMI, she was taken up for the primary procedure. This was the left shoot. The LCX was normal. LAD is normal. So the left system was normal. So the RCA, if you could see, there was a huge thrombus load in the mid part of the RCA, and the distal RCA was the PLV was almost totally occluded with a TIMI0/1 flow. So this was the situation of 40-year-old female, 3 hours duration of chest pain, STEMI. So if we initially always grade the thrombus in STEMI, we use the TIMI thrombus grading system, which is grade 0 is no angiography visible thrombus. Grade 1 is a possible thrombus. Grade 2 would be definite thrombus, but the largest diameter of the thrombus, largest size of the thrombus is less than 0.5, half the vessel diameter. If it is anywhere between half to less than 2 vessel diameters, it's grade 3. Grade 4 is more than 2 vessel diameters, and of course 5 is a complete thrombotic obstruction. So a large thrombus load means grade 4 and grade 5 are generally classified as a large thrombus load or a massive thrombus load. Another interesting, probably angiographic indicator of large thrombus load, this was given by Yip and colleagues, which suggests that any of these patterns generally indicate that there is a high thrombus load. A sudden rapid cutoff pattern of occlusion, an accumulated thrombus proximal to the occlusion, or if you have a floating thrombus proximal to the lesion, a persistent diastasis distal to the occlusion, and if the reference diameter of the infarct-related artery is huge, ectatic arteries, an incomplete obstruction with an angiographic thrombus, and of course the greatest diameter being more than 3 times. These are some of the other possible indicators that we are dealing with a high thrombus load, as was in this patient. Then in view of this, I did a manual thrombus aspiration. This was a Medtronic aspiration catheter. These were the thrombus which was aspirated from the RCA, but still post manual thrombus aspiration, the thrombus load was still present. So I did an intracoronary thrombolysis. Dr. Vinod Kumar sir was mentioning that intracoronary thrombolysis with tenecteplase is widely done. There was a paper by Dr. Jayagopal who had probably 10 to 12 patients, which was published, and it is rightly called as the Dr. Jayagopal protocol, wherein intracoronary tenecteplase is administered 1/5 of the systemic dose is given intracoronary. The remaining 4/5 is given immediately IV bolus. The patient is maintained on heparin infusion for 12 hours so that you keep the APTT up to 2 times the upper limit of normal. And we monitor the patient in the ICU. Chuck angiography was done after 6 hours. And since I had used a femoral approach, so the sheaths were removed 12 hours after the tenecteplase. Generally, if a radial is done, you could remove it after the Chuck angio. So we did an intracoronary thrombolysis with tenecteplase used with this protocol, and this was the final shoot. If you could see, there was almost complete dissolution of the thrombus from the mid part. This was check shoot 6 hours after the intracoronary thrombolysis, and even the distal flow was TIMI 1 bar TIMI 2. So now an introduction on the large thrombus load. We usually see this in STEMI. Some angiographic evidence is seen in 91%. Massive intracoronary thrombus is seen in 16%. Despite the availability of dual antiplatelets, GP2B3A inhibitors, effective anticoagulation regimens, large intracoronary thrombus still remains a big challenge to our cardiologists. There is still no ideal management strategy. Basically, it is the disruption of the plaque or plaque erosion, which thus causes a huge occlusive thrombus responsible for STEMI. There are certain factors which favor a large thrombus burden. And to my surprise, and this was a new point to me, wherein it is said that RCA, because it tends to have a larger burden of thrombus, probably because of proximal propagation of thrombus related to fewer branch points. So amongst the coronary vessels, RCA tends to have a larger thrombus burden. We have seen even in our practical experiences, but but this was the reason was something new. Now, why is this STEMI-associated thrombosis a bad thing? Large thrombus burden has increased MACE rates, increased risk of stent thrombosis, probably we undersize the stent, and there is an increased risk of malopposition, under-expansion, stent thrombosis, distal embolization, no flow. Thus, we know the consequences of no flow being larger infarct, lower survival, higher rates of CHF. Large thrombus burden and no reflow, they are not the same things. Nonetheless, no reflow can be because of large thrombus burden. So some amount of the treatment and the management strategies probably overlap. So the best way to treat acute coronary thrombosis is a combination of pharmacological drugs and intervention. How do we usually manage thrombus burdens? Radial access, unfractionated heparin as an anticoagulation, proper P2Y12 loading, especially with ticagrelor or even prasugrel once you know the coronary anatomy. Late presenters, difficult to cross occlusions, and at times wherein you have a TIMI grade 5 thrombus, total occlusion, then it is said you generally use an undersized balloon to see to it that there is some flow and reassess the thrombus grade. Anything more than 4, we do a mechanical thrombectomy, of course, GP2B3A inhibitors. If despite these measures, TIMI flow is suboptimal, you continue with an infusion, intracoronary thrombolysis, deferred stenting. So I would just be presenting 2 to 3 slides on what we did, that is mechanical thrombectomy, intracoronary thrombolysis. So why did a routine aspiration thrombectomy phase out? Because in an article in NEJM 2015, which showed that routine aspiration in cases of STEMI did not improve the primary outcome. In fact, the incidence of stroke increased in patients in whom routine aspiration thrombectomy was done. That is why it then became a class 3 indication for routine aspiration thrombectomy. Other studies like TASTE and TOTAL did not show benefit with manual thrombectomy. That's why 2021 guidelines said no benefit with routine thrombectomy. But routine aspiration thrombectomy doesn't. Is it that the routine thrombus aspiration thrombectomy doesn't work, or manual aspiration thrombectomy doesn't work? Now, with the availability of the penumbra mechanical aspiration, there are a few differences. In manual aspiration, the vacuum decreases as the fluid fills the syringe, whereas in mechanical aspiration, it has a more consistent vacuum for the duration of the procedure, better results. There was a study, which is the Cheetah study, which was published in the TCT, MD, I think this was in 2021, wherein for a high thrombus grade, they used this penumbra mechanical aspiration catheter, and the endpoint was MACE, CV death, recurrent MI, cardiogenic shock, NYHA class heart failure. So there was almost around 370 patients which underwent this. Yeah, and the lesions again, and whether they were STEMI, both STEMI, non-STEMI. There were stent thrombosis patients also who were included, and with the location of the arteries were almost all the arteries. If you could see the passes which the catheter pass was only once, whereas in manual aspiration, we do probably 3-4 times. I did 3. I had to do 3 times the manual aspiration, and the time is 69 seconds. This was the average time. I'll just come to the conclusion of it. Yeah. So this basically, the final TIMI thrombus grade 0 was achieved in almost 99.5% of the patients. Final TIMI flow 3 was in 97.5% of patients. Myocardial blush, 99.8%. Distal embolization was less, and there was no device-related serious adverse events. So this basically established a high rates of thrombus removal, flow restoration, and myocardial perfusion normalization. So these results are promising and showed that there is a difference between mechanical aspiration versus manual aspiration. So this is helpful in patients with high thrombus burden. Now, intracoronary delivery of a thrombolytic agent, as discussed earlier, the first trial was the dissolution trial, which used urokinase, and it showed that there was a higher TIMI3 flow, more blush, more ST resolution, and a lower TIMI frame count. But Altiplase was used by McCartney et al., and it showed that it did not improve the outcome. It did not reduce microvascular obstruction and major cardiac events. In fact, this study was stopped earlier. There are 2 trials which have been undergoing, STRIVE and the RESTORE MI. STRIVE is using tenecteplase, but I believe these results are out. Somehow I'm unable to get these results. But these results are promising, and Dr. Jai Gopal has also published in the Indian Heart Journal of his experience and the protocol which we used. Deferred stenting, of course, has some of its advantages and disadvantages, but it should be noted that deferred stenting should only be done and can be done in patients who have a TIMI3 flow. It should never be done without restoring a TIMI3 flow. The advantages is you probably prevent slow flow or no reflow. You then could end up, you could use a larger stent set because you undersize in most of the acute conditions. You could have lesser number of stent implants, smaller infarct sites, lower thrombus burden. But disadvantages, reocclusions are high. Therefore, you should carefully decide these patients. Routine deferred stenting is a class 3 indication. Since I said no reflow and a large thrombus burden, though they are not synonymous, but large thrombus burden is a significant reason for no reflow. I wouldn't go into the details of the definitions, but nonetheless, if you have no reflow, we know the infarct size is higher and the 5-year survival is lower in patients of no reflow than who have a good TIMI-3 flow. There are various factors which are involved in the no reflow. We have the patient clinical factors, pathophysiological factors, procedure-related factors, of which our high thrombotic burden is one of the major issues and causes for a no reflow phenomenon. No reflow could be macrovascular because of distal thrombus embolization, microvascular also. Now, pericytes, which basically cover which are found around, are gaining a 2022 December article, which says a lot of importance been given to pericytes in the causes of no reflow. So the treatment for no reflow be drugs, catheters, the pumps, the assist devices are known in probably our last resort would be assist devices. There was some debate over how you administer these drugs, whether it is directly via guide. Directly through the guide is cheap and easy, but at times may not reach the peripheral circulation if there is a complete occlusion and reflux into the aorta. That's why there was this clear way catheter which was introduced. It has a micro pores which releases these drugs. The cost and availability is an issue. And of course, we use micro catheters and also at times people have used even the aspiration catheters to give distal delivery of these drugs. Again, I think the drugs which we use, this is a very good flow chart for no reflow phenomenon, which basically takes into consideration bradycardia and hypotension. Why bradycardia is adenosine is a wonderful drug for no reflow, which we usually avoid in cases of bradycardia. Again, sodium nitroprusside again is a wonderful drug. It is better than nitroglycerine because sodium nitroprusside has both vasodilation properties of epicardial coronary arteries as well as the smaller arterioles, whereas the nitroglycerine only has the epicardial coronary artery vasodilatation. I'm sure I wouldn't be going to the details of the doses of these, but commonest which we use is adenosine, sodium nitroprusside, verapamil. Personally, I don't have much experience of using intracoronary verapamil for no flow. Probably the panelists, if they have any experience of calcium channel blockers, we could discuss that. And of course, intracoronary, a word on intracoronary GP2B3A inhibitors. Intracoronary has a theoretical advantage of being better than IV, but there were a few studies which were published. That is the IDA-STEMI study, which showed that intracoronary and intravenous did not have much difference, but there are smaller studies which show intracoronary delivery of GP2B3A inhibitors have a better dissolution of the thrombus. These are the drugs and the dosages which we use. So finally, how do we manage high thrombus burden? Again, just to have a good take-home message, radial access, good preloading with drugs, mechanical thrombectomy, aspiration thrombectomy is still very useful in certain subsets. Intracoronary GP2B inhibitors, continue them in infusion. Intracoronary thrombolysis in select group of patients. And of course, again, deferred stenting. One more, I think imaging also helps a lot in such individuals, especially in our case, wherein what was the cause for plaque? Was it a rupture? Was it an erosion? And that would probably help us in the further treatment as well. Since I didn't do imaging in our case because our OCT unit was undergoing assembly. They had angio co-registration, which had to be assembled the day I did this case. But nonetheless, imaging is a very important tool to decide the next possible step as well. So concluding, high thrombus burden in STEMI is commonly encountered clinical problem. Mechanical thrombectomy is promising. Adjuvant pharmacotherapy, intracoronary fibrinolysis might have a role in the current era of primary PCI, especially in young STEMI, huge thrombus burden, and in patients who present relatively early after chest pain, thereby avoiding unnecessary stenting and complications. Thank you.
Excellent talk, Amit. Excellent. Very good case. How do you strategize whether to go for GP2B3A inhibitors or for IC, intracoronary thrombolysis?
I think first we always give intracoronary GP2B3A inhibitors, and in spite of that, we feel that the thrombus burden is still high. Then I think that is the time when we think of intracoronary thrombolysis. And as in this case, if you see the thrombus, the way the length of the thrombus grade 4, you actually have an image that this wouldn't probably go away with just 2B3A.
So that's the reason you didn't go for GP2B3A in this case, right? So initially you thought the thrombus burden is very high, so you avoided GP2B. Directly you went for IC lysis. So what happens is, when we are doing regularly, the pressure from the operator point is we would have loaded with IC GP2B3A and we would have started infusion with GP2B3A. Still, the patient will land up in no reflow phenomena, where we are pressurized to use again intracoronary lysis. That time, the pressure is whether the patient will bleed or not. For example, your patient is a very young patient, where the relativity of going for a bleed is very less. But in the elderly population, 50, 60 years, when we are landing up in a complication, in spite of being on GP2B3A, then we have to use IC. That time, the pressure on the operator is significantly high. How do you feel that? Whether you are okay after going ahead with GP2B infusion, IC, everything, and then giving intracoronary?
Elderly, I think if you see, even as I said in my concluding remarks, it is more helpful in younger patients, earlier presentation. The older the patients, of course, I think the beneficial effects of intracoronary thrombolysis is offset by probably the bleeding risks. And many of the studies and the journals articles give a very red flag alert of using intracoronary thrombolysis in elderly individuals.
Yeah. That's the point. I just want to take it forward to the audience, young cardiologists who are looking into it. So it should be a last resort when you are trying to give an intracoronary thrombolysis. So you have to be very careful, and depending upon the drugs which are using prior also should be considered when you are choosing to use a IC lysis. Then second thing, very good point, Penumbra. Penumbra is a very good device. Now they have marketed even in India, and we have this system for pulmonary thromboembolism extraction. And currently we have used about 3 cases in our center. But I have attended a meet even in this company as Indigo. This is promoted by Indigo. And we had a meeting in Thailand recently, 6 months back. But the problem what we are facing is Penumbra, the Catrax system is our coronary vessels. I'm not sure about your state. In Tamil Nadu, we find the vessels are a little smaller. And using a system with a large bore access like Penumbra with automated system, how much it is possible, that is one question we are left with. We are not sure. But of course, if you have a large RCA like what you have shown, obviously Catrax, when it is available here freely, and if the cost is not a problem, it's a very good option. Then probably instead of doing a mechanical thrombectomy, taking, as you have mentioned, for multiple process, as you have done for 3 times in your case, this is a very good alternative, as you said. Whether you have used any Catrax, because we have used only in pulmonary embolism, we have not used in coronary so far.
No.
Oh,
I
sure.
have not used it.
Yeah. And regarding the drugs usage, we are discussing about the drugs, intracoronary drugs. We commonly use, as you said, SNP, adenosine. My usage of verapamil is very, very less. But I use a lot of times nicorandil. Nicorandil usage of ours is very high. So I just want to tell the audience, if your blood pressures are on the lower side, we prefer nicorandil instead of NTG. A lot of times in labs we use NTG, but when the patients are very lower side, about 80, 90 systolic, when you are dealing, instead of NTG, we can use this nicorandil. And of course, as mentioned by him, Amit, SNP is a very good drug. Excellent drug. Whenever our anesthetist is always ready when we go for a cardiogenic shock patient in the night, and I preferably use SNP. And sometimes whenever, in spite of giving nicorandil, NTG or some other drug, adenosine, if it's not improving, what we do is we generally take a microcatheter across the lesion, distal to that occlusion, and then we give the drugs via the microcatheter. And a lot of times it works in our setup. And we have done so many of the patients, and it was very useful. So if you have no reflow phenomena in your patients, in spite of using your drugs, a lot of times we don't have in our shelf many of the instruments. So that case, you can take a microcatheter, take the drug, inject it distal to the lesion. A lot of times it gives way and it opens up, the flow starts establishing. That is another point. And as you
could use a burst the balloon and then probably use it. That also is done for distal delivery of.
Granuloplasty is also recommended if you're considering a distal flow, you have to be established. So you can take a 1 or 1.25 balloon, go for RBBB, burst the balloon, then establish a pathway, then you can give the drug. That is also a very good idea.
And one more, I think intracoronary nicorandil has to be given probably slowly over 2 minutes. That is a very important thing again, because sudden, if you give a bolus immediately within seconds, we have seen patients going into ventricular tachycardia, and in fact, we had to shock this was initially when probably 6-7 years back when Nicoran was used. So that is again a very important word of caution to give Nicoran 2 to 4 milligrams slowly over 2 minutes.
So what I tell my postgraduate residents who are always accompanying us during a primary PCA is count, always count. Give a small 1 cc, count 1, 2, 3, 4, 5. Then one press, small press, 1, 2, 3, 4, 5. Give time. Once you reach off the syringe of 2 mg, then give 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Count 10 and then go for it. So always we give nicorandil in this fashion, and probably over 1.5 minutes or 2 minutes, and we will feel very comfortable once the strategy is. Initially, we also don't know. We are used to give, we are in almost in every pressure to open the vessel and no reflow, everybody will be tensed. And as you said, 4 or 5 years back, we used to give complete press and always we land up with complications. Nowadays, we have slowed down and we give very slowly intracoronary Nicorandil. That also works. But certain centers use infusion. But our center, we don't follow infusion protocol. Only we use only 2 mg. If in case we want to repeat also, we give some time space for the flow to occur, then use the Nicorandil another 2 mg after probably 1 or 2 minutes. That's how we follow our protocol in our center. So that is also, and deferring a stenting in a young patient, excellent method. It's a very good thing to be done for a young patient. That should be the courage of the young cardiologists who are watching this. When, as Amit said during his talk, if you achieve a TIMI3 flow, then if it is very clear, then you have time. As he said, you can put them on either GP2B3A infusion, or if you have used lysis, you can go ahead and maintain them on heparin. Always we can go for a recheck angiogram. You will be on a better mind of state the next day with a wonderful team around, senior people, supportive staff, everything is better. And you have a very good clarity now whether to stent that segment, how long to stent the segment. As he mentioned, a lot of times what happens if you do it in a high thrombus burden, you go for a very large stents unnecessarily. When you do it after a day, you can locate the culprit point wherever it is and then address exactly that lesion alone. So a lot of times what happens is we don't require a stent when we do a redo angio. As shown by Amit, it is the wonderful recanalization of the vessel with a TB3 flow. Probably the patient has acquired as native coronary vessel. So it always depends upon the interventionalist who is addressing the lesion. So we have to be morally, ethically responsible for our patients. It is not only delivering the stent is important, giving an effective care to the patient at that point is very, very important. And my best wishes for you, Amit. It's an excellent case. And as I said, we have done imaging studies in our patients whom we have done intracoronary, and we have documented the lotus stem appearance. Most of the times it is recanalized vessel. As a lotus stem, like if you cut, there are multiple pores. We see a good, very good OCT image. I couldn't recollect from this laptop. I'm in my clinic, but we have images of OCT with a recanalized vessel. And so in patients, once you do a imaging, we don't do on the day. Once we are taking up for after 48 hours for check angiogram, we put a imaging OCT catheter and check. And a lot of times we happen to see a recanalized vessel. So that's a very good thing. And I am for deferring in a young patient, if possible. If not possible, then there is no doubt you have to go and stent it. If possible, if you are able to achieve a TIMI flow, young patient, please wait. We have a lot of time. And if required, we can go and stent later. So these are the points I could gather from his talk. And it is an excellent talk. One of very good talks. See, a lot of times people deliver a lecture, but they are very too fast to the others to catch up. But this was excellent delivery of lecture, and we are all able to gather all the points what he has able to deliver today. It's an excellent talk, Amit. Congratulations for you. If there are any more questions from the audience, probably we are ready to take on them point by point.
If Dr. Pramod sir could probably
Pramod has left for emergency, he has told me.
Okay,
so probably we will continue the discussion.
Yeah, yes.
So there's just one question from the audience for now. Dr. Vinay wants to ask how to deal at the periphery when the PCI facilities are far away and it takes 3 to 4 hours.
No doubt we have to lyse the patient. There is no doubt. If the patient is in the window period, if the patient, we have a lot of studies, as even quoted by Amit, we have Indian studies also, which says when the patient is in the window period, within 3 hours, both lysis as well as PCA have the same results. So if you are in a periphery, no doubt, even 6 hours, 12 hours, if the patient is there, ongoing chest pain, ECG changes, then go ahead and lyse it. Always there is a benefit of lysis rather than doing it. So I strongly believe in a periphery before transferring the patient, because a lot of times what happens, for example, I had a case scenario. One of my relatives were in distant south and they have to travel to a district headquarters 1.5 hours from the place where they have to travel. So the doctor there, he got him checked and found to be patient to be in STEMI. And he wanted to give his very close friend, so he wanted to give him the best of shot. So he shifted the patient to the district headquarters for a primary PCI. Before the patient could reach the district headquarters, on the way in the ambulance, patient got arrested, and they could do CPR, but they couldn't revive him. So that patient is one of my relatives. He's a contractor. His age is just 52. So whenever you are doubt of transferring a patient to a center, and it is going to take more than an hour's time, probably the best thing to do is lyse the patient, then refer the patient for further management. If you are very sure that you can shift him a patient on an ambulance facility with all the life supports which can be handled during the travel, then you can transfer the patient. Otherwise, I will strongly recommend to lyse the patient, stabilize the patient in your center, then shift the patient for a further management of AMI. That's what I would do. Amit, your ideas, please.
A very correct point. Pharmaco-invasive therapy, I think, is best. And a lot of studies have even shown that pharmaco-invasive therapy and primary PCI have the same probably outcomes. And I think this strongly has to be percolated amongst the physicians and peripheral probably practitioners that if the patient cannot be shifted in less than 60 minutes, lyse. They always feel that if you transfer the patient, let it be 2 hours, 3 hours, primary PCIs is better. They are giving the best treatment. I think it is in part probably that the hype of primary PCI being more than more than thrombolysis, irrespective of the time. I think to some extent we also have to be blamed because we have portrayed primary PCI to be so great that the time is being neglected, and this message has to go in very straight to all the peripheral consultants. Even in hospitals where you have a primary PCI facility, the cath lab is occupied and you have a STEMI patient. Even in him, if you think that you cannot do it within 1 hour, it is better that you lyse the patient.
Thank you, sir. There's one more question from the audience. This is, I think, to Dr. Amit. Since you spoke about the studies comparing intracoronary and intravenous, could you please expand or elaborate on those studies, sir?
Yeah, there was the IDA STEMI trial, which basically used intracoronary apixaban compared to intravenous apixaban. This is only the bolus doses of GP2B3 inhibitors, which showed that the primary outcome was similar if you give apixaban intracoronary or intravenous bolus. But as I said, there is a theoretical advantage of giving intracoronary apixaban as to more local delivery, more local action, more probably dissolution of the clot. And I think even practically we have seen that. Practically we all give intracoronary because of our experience. So a bolus intracoronary apixaban is the wideliest studied GP2B, at least in our part. Though few centers, especially I think European centers or America, use aptifibutide a lot. But I think in India, universally, most of us use apixaban, and we are comfortable with intracoronary, though the studies have shown that both have the same effect. Vinod, sir, any?
Yeah, I'll add only one point. See, the thing is, you will be in such a messy situation when you are going to use this drug molecule. And giving them IV and waiting for the action to happen, that will not be your mindset when you are dealing with a STEMI patient, primary, no reflow phenomena, very sick case, cardiogenic shock. I have personally seen, Amit would have seen, all my seniors, my teachers, everybody has taught us intracoronary is always good. And we have been seeing it need not reflect in guidelines or on paper, but by practical experience, I'm very sure if you want to try, you please give intracoronary and then start infusion. Nothing will happen to the patient. And we have seen a better results with intracoronary rather than giving IV alone. So I always initiate my GP to be 100% intracoronary on my patients. Unless I fear this patient is very, very elderly, 75, 80. I'm worried about bleeding risk. Then only I go only for intravenous on a lower dose. Otherwise, on table, IC is preferred. When your catheter is inside, you can directly deliver the drug there. And probably if there is a 1% extra advantage, I like to deliver that advantage to my patient. So that's how I see this trials. So you need not worry, you can give.
Okay, sir. Thank you. Since we are talking about intracoronary, there's a question from the audience by Dr. Sami. He wants to know what is the dose you use for intracoronary thrombosis with tenecteplase.
Clearly, Amit has mentioned, no, it is 1/5 of the dose of intracoronary whenever, whatever based on the weight, 0.5 mg kilogram, then calculate the dose, give 1/5 as a bolus, followed by remaining amount as an intravenous. Only one case, if the patient has a stent thrombosis and then you want to give intracoronary, then the protocol slightly varies. You have to give 2 times 1/5 of the dose as a bolus. First, initially 1 time, then do multiple balloon dilatations and aspiration. Then another 1 time 1/5. The same Gopal protocol is there for stent thrombosis also. There it slightly differs from this primary, where only in primary STEMI we give only 1/5 as bolus, remaining as intravenous. Here in stent thrombosis, if you want to deal with a large thrombus burden, we are supposed to give 2 times 1/5 of the bolus dose, followed by IV, followed by maintenance with heparin infusion. So always 1/5, remaining intravenous. That should be the idea.
Okay, thank you, sir. So there's one last question, I think. So since we're discussing about young STEMI, does the treatment protocol differ for young STEMI patients when compared to the older age group, or is it the same?
Treatment protocols are same. We have to be a little more aggressive in a patient, is a young patient. So saving the myocardium is always very, very important. In elderly population, we find a lot of times calcium, plaques. So stenting differing is going to be very, very difficult. It will be a mixture of both a plaque lesion, heavy calcified lesion, along with the fibrotic plaque with the thrombus containing lesion. But in young patients, we usually see only thrombus. There is no lesion at all, most of the times. So the strategy of differing stenting is very much conceptually correct, and it is easy to be applied among young patients rather than in an old patient. Otherwise, our usage of drugs, we are able to use almost every drug without the fear of bleeding risk. That's how I'll put a point. What about Amit? What is your idea?
Yeah, exactly. Unless the patient is very elderly, I think our management strategies won't change much when we're treating with STEMIs. But now we usually see younger individuals also who come with STEMI having calcium, having triple vessel disease, more aggressive atherosclerosis. That's a different topic altogether. But then unless very elderly, our strategy for STEMI necessarily does not change. But as much as possible, younger individuals have more thrombotic occlusions, and you could probably defer stenting. Stenting is also like you are giving one more disease to them. So I think proper use of the intracoronary thrombolysis and deferred stenting should be done. That should not be indiscriminately applied to all the younger patients. This is in a very select group of patients. You still end up stenting many younger patients. Probably more than 80% of all young STEMIs we end up stenting. This is for only probably the 10 to 15% of patients.
That is very true. It is only a judgment on the day when you are operating. So we have even patients at 24, 26 with triple vessel disease who have undergone even bypass surgeries in our regular follow-up. So now age is not a criteria. We are seeing severe disease among even young patients. But you should know where to differ. That is what Amit has shown a clear-cut case. That is a very good example where you can differ stenting. Otherwise, all regularly we stent every patient. So that should be the idea. If there are no more questions, can we end up, Ma? Any
Yes,
thought?
sir. Yes, sir. I think that's it. We've come to the end of today's session. Now I request Dr. Vinod Kumar sir to give his closing remarks for today's session, sir.
Okay. A wonderful session. Thank you, MQ, for a wonderful program of workshop on AMI. This will create a very good awareness among the young cardiologists who want to treat such a complex cases and do a primary PCI in their centers. And it's also useful for physicians when how decisions are made at the cath lab, so that when some cardiologist is communicating to them, they will be able to understand why they have stented, why they have not stented. So anyway, across the spectrum, this kind of initiative is going to be helpful for everybody, both cardiologists as well as physicians. And today's talk by Amit was excellent, and the case demonstration was very useful. And the way he has presented the data based on the papers and articles, it was an excellent oration. And we have learned a lot of points today. Probably in coming days, we should be able to apply them in our day-to-day practice. That will be the real usefulness of this program. And I thank once again all the organizers as well as the speaker for this wonderful program, and the audience for listening to us very patiently. Thank you, Pramod Kumar sir, also.
Thank you. Thank you. Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir. So with that, we come to an end of today's session. It was a wonderful and insightful workshop. I would like to thank Dr. Amit sir for his informative presentation, and Dr. Vinod Kumar sir and Pramod sir for your expert comments and great practical insights. We would really like to work under your guidance for many such future programs. With that, we will close this session. Thank you everyone once again. Bye and have a good night. Thank you so much, sir.
Thank you.